Faraz for the kind invitation to the FALS Bariatric 2021 and hope to join the question and answer session for more discussion. My name is Abdel Rahman Nimeri and I'm going to speak to you today about sleeve gastrectomy revision. This is my disclosure slide. It has no relevance to the presentation. You can see most of the surgeries I do are Roux-en-Y gastric bypass. Sleeve gastrectomy represents about 37% of what I do and 16% of revisions. So I'm going to talk to you about how to define weight regain after sleeve gastrectomy. Specifically, when someone has reflux or dysphagia versus weight regain after sleeve gastrectomy as reasons for revision. And does it make sense to have a staged approach for super obesity? And then finally conclude by talking a little bit about the total alimentary limb length when you choose an intestinal procedure to revise or convert a sleeve gastrectomy to an intestinal procedure. We need to recognize that weight regain is a normal process after metabolic and bariatric surgery, and you can see the different reasons in this slide for weight regain. So you can see in the Swedish obesity subject study, the amount of weight regain that happens after bariatric surgery between year 1 and 10 is quite common, but it's different depending on the procedure. So this is another study from the VA hospital system showing that best medical therapy in blue to surgery, but also showing that gastric banding in orange compared to in the middle sleeve gastrectomy, and in the bottom Roux-en-Y gastric bypass between year 1 and 10. So weight regain does happen after surgery. The question is how much weight regain is significant, and there's really no uniform or internationally recognized definition. It is important for us to not use excess weight loss because it is not used by our medical colleagues, and also it gives a wrong impression depending on the patient's BMI. So it will be falsely elevated in a low BMI patient and falsely low in a high BMI patient. So the best definition to use is a definition recognized by the ASMBS position statement from 2015, in my opinion. So change in BMI, percent total weight loss, and percent BMI loss. And you could include excess weight loss just because historically studies have included that. Now let's come to sleeve gastrectomy. We know that sleeve gastrectomy worldwide is the most common operation done. In 2018, it represents more than 55% of procedures done. And this is the same whether in the European chapter on the left, the North American chapter on the right, or the Asia Pacific chapter where you are on the left, or the Latin America chapter. Is the only chapter where still Roux-en-Y gastric bypass is the most common surgery. Now, if you look at outcomes of sleeve gastrectomy, sleeve gastrectomy is a good operation. So a recent study this year merged 5-year outcomes of the two largest randomized controlled trials, the Finnish sleeve pass study and the Swiss FALS study. And what they did is they looked at how many patients they had at baseline, 228 in sleeve gastrectomy, 229 in Roux-en-Y gastric bypass, and they looked at their outcomes at 5 years. And the mean estimated excess BMI loss was 7% better for Roux-en-Y gastric bypass, 62% versus 55%. And there was no difference in resolution of type 2 diabetes, sleep apnea, quality of life, remission of hypertension was better in Roux-en-Y gastric bypass. So, I mean, to start and have a baseline, sleeve gastrectomy in selected patients is a good operation. Which patients do I select for sleeve gastrectomy? Low-risk patients without diabetes and no reflux. I also selected for low BMI patients. I specifically also selected for high-risk patients. And then there are specific patients like patients with Crohn's disease or significant adhesions that might benefit from sleeve gastrectomy. So in the FALS and sleeve pass study combination, you can see that the complication rate was higher in Roux-en-Y gastric bypass, but there was no difference in the mean comprehensive complication index. So if you have a high-risk patient, it actually makes a good sense to offer them sleeve gastrectomy. So gastric bypass has better weight loss, but not by a significant much. And the resolution of comorbidities is quite similar in both, and there are more complications in gastric bypass. So what are the causes to need to revise sleeve gastrectomy? In this multi-center trial from Austria, reflux and weight regain were the most common causes. How many patients required revision? 14% in their earlier series, as I will show you, 33% in their later series. 23% of patients were weight regain, the most for reflux. Another study from Taiwan showing 21.5% revision of patients, and half of the patients had de novo reflux. The need for revision was rather mostly for reflux. And this is the study I told you about, the longer study from Progress Group, showing that 33% needed revision and reflux was the main reason, but some patients needed conversion for weight regain. Now, when you operate on patients, should you operate? Should you wait? What was the starting BMI before sleeve gastrectomy? What's the BMI at the time you're seeing them? Makes a difference. Did the patient maintain 10% total weight loss? Is the patient high risk? What's their age? What's their cardiopulmonary status? What is the current BMI? Do they qualify or meet criteria to have metabolic and bariatric surgery? What are their obesity-related medical problems? Does the patient have reflux? And if they have reflux, did you evaluate them objectively with pH study and manometry? What's their assessment from the rest of the team, and how compliant were they from the initial operation until they came to see you in terms of follow-up on vitamins? Our workup for these patients includes an endoscopy. Typically, I do the endoscopy myself. When I do the endoscopy, I look for the area of the fundus and see if there is a retained fundus. I look at the Z-line, evaluate the patient for presence of Barrett's. I make sure to look at the incisura and their antrum, see if I can retroflex in the antrum. And we do an upper GI barium study to look at the evaluation of the esophagus, especially if the patient has dysphagia. We might do manometry. In all patients with reflux, we do a pH study. If we suspect bile reflux, we do an impedance test with a nasal catheter rather than a Bravo capsule study. And then they get evaluated by the team and get a complete nutritional evaluation, and we evaluate their compliance. All these patients are seen by a board-certified obesity medicine specialist as well. Now, when we think about surgeries for sleeve gastrectomy, most of them are conversions. ASMBS put a task force to evaluate revision surgery since it's very broad. Reversal, conversion, or correction are the three types of surgeries. So the starting BMI dictates the final BMI. This is extremely important. We have to treat obesity like we treat cancer. If someone comes with stage 3 cancer, the initial treatment might not be surgery. It might be adjuvant therapy, it might be other forms, radiation. And I think in our patients, when someone comes with a BMI over 50, we might try measures to get that BMI lower, especially if it's over 60, over 70, using a robust MDT team, because starting BMI dictates final BMI. This is a large study of more than 9,700 patients published in JAMA from the group in Michigan, and it shows that if your BMI is above 40, your chances of getting a BMI below 30 1 year after bariatric surgery is different than if it was below 40. If you look at this meta-analysis, it confirms the finding from the JAMA study. If you look at patients and how many BMI points do they lose, in general, 12 to 17 BMI points, a little higher in gastric bypass, a little lower in gastric banding, but sleeve appears to be more effective than gastric banding and quite comparable to gastric bypass. So if you get someone with a BMI of 60 and you offer them a sleeve gastrectomy, they need to know that they will lose 12 to 17 BMI points, maybe regain some weight at 5 years, and they should have a realistic expectation. This is a 10-year study by Kelvin Higa's group showing that if you look at patients over a 10-year period, the graph at the top is patients with BMI less than 50. The graph at the bottom is BMI more than 50. So you get Same procedure, same group, two different outcomes depending on the starting BMI. And it seems like the antrum size is still something we talk about, but it's not clear whether resecting the antrum or leaving it makes a difference. This is a randomized trial from the group in France, randomizing 172 to 174 patients to either resect the antrum with coming very close when you start resecting to the incisura, the pylorus rather, or going wider. And they found that the reflux, which was analyzed by pH, was no different at 3 months, and no difference in weight loss between both groups at 1 year. So it seems like going farther from the antrum or coming closer, we still don't know what the best answer is. So in this study, they had similar complications, and excess weight loss was similar between both groups. Should you ban the sleeve to prevent needing to revise it? It seems like there is some evidence to support that. This is a randomized trial of 94 patients, excellent follow-up, 97% at 3 years, and it seems like the patients who had a banded sleeve did better than the patients who didn't. In terms of weight loss, in terms of remission of type 2 diabetes, and implanting a ring correlated with less frequency of symptomatic reflux episodes, which is interesting because it was not objectively tested, but higher incidence of regurgitation. And the rate of complications was similar. Quality of life, surprisingly, was better after banded sleeve because it seems like patients value weight maintenance the most. Can you re-sleeve a sleeve gastrectomy? This study with quite good follow-up in a small number of patients showing that half of them will have reflux at 3 years, and the results are quite disappointing. So it does not seem like re-sleeving a sleeve gastrectomy is a good revisional option. So what do you do? This is a very important study from the multi-center Dutch group, 10-year study looking at 140 patients, and they either had a SADI with 250 centimeter common channel or gastric bypass with 150 centimeter rule limb, BP limb rather, and 100 centimeter rule limb. And the SADI patients did better, weight loss up to 2 years. Major complications were quite similar, including nutritional deficiencies, a little higher in the SADI group, but did not reach statistical significance. So it seems like if your patient, their main concern is weight loss, it's better for them to have a duodenal switch or the SADI version than to have a Roux-en-Y gastric bypass. So you can see in this study, once the 3 months passed, there is a divergence in their outcomes. And it's important to note when you do duodenal switch that the results of the 10-year trial, Mingroni trial for diabetes are out, and it seems like there's significant nutritional deficiencies. The weight loss is excellent. When you compare bypass and duodenal switch, there is more significant and serious nutritional deficiencies in the BPD group, which is like the European version of duodenal switch that's mostly done in the US. So it seems like it does not make a lot of sense to have a staged approach, especially if you practice in a place like the US where insurance is an issue. So I want to conclude by talking to you about the importance of deciding the total alimentary limb length when you convert a sleeve to an intestinal procedure, especially because as I know from my time when I was in Abu Dhabi, the most common conversion of sleeve gastrectomy in the Middle East, Asia Pacific, specifically in India, is 1 anastomosis gastric bypass. You need to recognize that the difference between Roux-en-Y gastric bypass on the left, BPD in the middle, or duodenal switch is the size of the stomach and the length of the total alimentary limb length and the length of the BP limb length. They're all surgeries with Roux-en-Y configuration. And if you focus on the bottom, you'll notice that the total alimentary limb length in Roux-en-Y gastric bypass is variable, but it's constant in both BPD and DS. And Roux-en-Y gastric bypass and 1 anastomosis gastric bypass have nothing in common except the name. Their stomach pouch is different, their BP limb length is different, and their total alimentary limb length is different. So you need to make sure you measure the common channel if you're doing one anastomosis gastric bypass. Or if you're doing any looped procedure, being DJB, jejunal bypass, SADI, you need to make sure to know what is the common channel or the total alimentary limb length, because in all looped intestinal procedures, the common channel equals the total alimentary limb length. So let me spend the next a few slides, a few minutes explaining the concept of the total alimentary limb length. So this is a busy table, but I'll take you through it. The first assumption you make when you're doing an intestinal procedure is you're assuming the length of the small bowel. So in this table in the top left corner, we're assuming it's 600. Roberto Tacchino did a study and found that the length could be as short as 350 and as long as 1050. So in about 10 to 20% of patients, it's less than 400 or more than 800. So if you look at the procedures in the top row, BPD followed by DS and SADI, and look at the second bottom row from the bottom, total alimentary limb length is the same in these three procedures. That's why the weight loss outcomes and the rates of protein calorie malnutrition are defined and well known. If you look at one anastomosis gastric bypass, if the small bowel length is 600, it's 400, the total alimentary limb length, because it's the common channel. In DJB, it's 350, and in Roux-en-Y, it's longer. That's why the incidence of nutritional deficiencies, even if you don't measure, are higher. Now, let's change that assumption and change the small bowel length from 600 to 400. You notice that BPD, DS, and SADI, nothing changed. That's why the incidence of nutritional deficiencies, the weight loss outcomes are similar. But if you look at one anastomosis gastric bypass, this patient could develop severe protein calorie malnutrition if you convert a sleeve to a one anastomosis gastric bypass, and could end up with liver failure. And you would blame the length of your BP limb, but what you should know is what's the length of your common channel. DJB, even more dangerous. You can see the protective effect of the Roux limb. It's 350, the total alimentary limb length. And then the last assumption, what is the patient's bowel, is 800. I told you, Tacchino said they could be as long as 1050. Again, BPD, DS, and SADI the same. One anastomosis, this patient could have now weight regain, and you'd blame the behavior of the patient, but what you should blame is not measuring the common channel. DJB 550, and in Roux-en-Y, it's even 750. So you need to know the total alimentary limb length when you convert a sleeve to an intestinal procedure. And you need to, if you measure from the ligament of Treitz, once you decided where you're going to connect the bowel, measure and make sure you have at least 300 centimeters of total alimentary limb length, because it's all about nutritional complications. So what's the take-home message? Patients with BMI over 50 are at a higher risk of weight regain, like a patient with stage 3 cancer. That is why when we see them, we need to initially do as much as we can with the MDT team to get them to lose as much weight as we can. And if we offer them sleeve gastrectomy, be realistic with them. Talk to them about the risk of developing reflux, and also talk to them about the fact that they might lose 10, 12, at the most 15 BMI points at 1 to 2 years, and then have weight regain at 5 years to maybe 10 BMI points from where they started, and see if that is what they desire, because that's an important point. The starting BMI dictates where you are 5 years out. The most common causes of revision after sleeve gastrectomy are reflux or weight regain. It seems like reflux is more common than weight regain. That is why when you see someone with sleeve gastrectomy, if they have reflux, you need to objectively test them. And if your upper GI shows any abnormalities, you might need to do a manometry on these patients. There's a new entity called post-obesity surgery esophageal dysfunction that can happen after sleeve gastrectomy, and you'll not know it unless you do a manometry. For patients with reflux, Roux-en-Y gastric bypass is the best procedure, and that's why reflux has to be defined objectively. For patients with weight regain, duodenal switch or the SADI version is better than Roux-en-Y gastric bypass in terms of weight loss. But it's important to note that revisional surgery has higher risk than primary metabolic and bariatric surgery, and it needs a comprehensive workup before surgery. It needs a robust MD team before contemplating surgery. And if you choose to do one anastomosis gastric bypass, make sure you measure the total alimentary limb length, because in looped procedures, as we said previously, the total elementary limb length equals the common channel. Again, I want to thank Sir Faraz for the kind invitation, and I'll be happy to connect and answer any questions. Thank you very much.